It's my pleasure and privilege to introduce our distinguished guest speaker, Dr. Clement Chan, who is consultant of Women's Health and Reproductive Medicine Center in Hong Kong. Dr. Chan graduated from Medical School of Hong Kong University in 1975, followed by his internship training in University Gynecology Unit, Queen Mary Hospital, Hong Kong. Since then, he has been experienced his academic activities in various institutes, especially in Asia area. His current position is Vice President and Asian Federation Secretary, ICS USA Council. Dr. Chan is also Secretary ICS Hong Kong chapter as well. Today, Dr. Chan gives us a mini educational lecture entitled is Laparoscopy Obsolete in the Management of Infertility in the Era of IVF. Dr. Chan, please start your lecture.
Thank you. Thanks a lot. I would like to thank all of you, our ICS fellow in Japan. As I mentioned, there's a couple of things we all want to learn from you, but we'll talk about later. I'm glad that I possibly is one of the only gynecologists in the audience, because in the last 10 years I was back from Australia to Hong Kong, I realized there were some reproductive medicine subspecialists who were very good in doing intrauterine insemination, in vitro fertilization, IVF, IVT, but their clinical sort of participation, especially in surgery, is very little. So there was this thinking whether if we train somebody to make a baby, all we need to do is train to do the insemination, just to do the IVF. Is that what it is? That we don't even have to bother about laparoscopy. Is that true that all the reproductive medicine surgery is excellent in this management of infertility in this era, IVF? But of course the answer is no, otherwise I won't be here, and then we don't need to be a surgeon. We can get the GP to do it. Now, there's many reasons why that we need to do laparoscopic surgery. For example, to make a diagnosis for the causes of infertility and treat accordingly without resorting to IVF. And also there are roles to diagnose different forms of Mullerian anomalies despite of the MRI's usage. And of course, when we used rightly, actually half the cases we don't need to go for IVF and we can conceive without IVF. For example, performing some adhesolisis or ovarian plexy. Then, of course, there are cases where we can improve the ART result, for example, removing an endometrioma, removing a submucous fibroid, doing ovarian drilling of the polycystic ovary disease, or removing hydrosalpinx. Then there are cases where the ovary was stuck very high up and you have difficulty getting it through the IVF, so we might want to reposition it to do the ovarian plexy for accessibility. Then, of course, we can fix up the ovary in case a lady who has some sort of cancer and need radiotherapy. We want to protect them from the ovarian failure. And there was that report that people have chemotherapy which might lead to ovarian failure. If you do some cryopreservations of the ovarian tissue and replant it later, then people got pregnant. Then in very early young women who have early cervical cancer, you may not need to remove the uterus, and you can do it with radical tracheectomy and laparoscopic lymphadenectomy, and they can still get pregnant. And finally, for the varicocele, which has been always a debate, there seems to be evidence that some form of varicocelectomy is useful. I'm trying to elaborate with evidence. First, diagnosed infertility. Nowadays, there are these people who always think whether we need to do laparoscopy for it. But this paper published in British Journal ONG 2009 very clearly say that if we want to try to diagnose it, that for tubal pathology, we can use HS, the hysterosalpingogram, laparoscopy, and both. They find out with various history, whether you cohort study or case control study, there are some indications to do early laparoscopy. For example, people have history of complicated appendicitis, pelvic surgery, pelvic inflammatory diseases, ectopic pregnancy, endometriosis, or sexually transmitted diseases. And these are the ones that you might consider early diagnostic laparoscopy because the chances of it having a tubal peritoneal defect is much higher. And there this paper was published in 2000 in British Journal ONG trying to question whether by combining a clinical history with features and like pelvic inferior disease history, pelvic pain, history of cervical epithelial lesions, and pelvic surgery, appendectomy, and some abnormal sign, and chlamydia antibody. By combining this, whether we can avoid doing laparoscopy. However, the study confirmed that with a history alone, and also with the chlamydia antibody, you might have diagnosed some of the tubal diseases with sensitivity of 90%, but specificity only 70%. But you cannot diagnose bilateral tubal obstruction diseases because the specificity is very low. And definitely, there are other pelvic pathology you cannot diagnose with sensitivity only 70% and specificity 70%. So the conclusion is, you still need to do laparoscopy selectively, and the history and chlamydia antibody is not good enough to avoid laparoscopy. And this paper was published in our clinical experimental ONG in 2012. It shows that out of 600 diagnostic laparoscopy for infertility, only less than half of them have no pathology, and more than half have some sort of pathology, the most common being pelvic adhesion and endometriosis, which you have no other way of making a diagnosis, and which sometimes treatment can relieve the condition and cause fertility. Therefore, the conclusion again, laparoscopy is an important place in diagnosis and planning for the management, and will save us a lot of unnecessary time waste and economic loss. Well, since the use of MRI, people will say, well, we don't need to do laparoscopy for diagnosis. That's true to a certain extent. Now they might replace some of the laparoscopy hysteroscopy. But however, in selected cases, like people who have coexisting gynec condition like pelvic adhesion and endometriosis, there's still a place for the laparoscopy. This lady was about 30-odd years old when she came for a primary fertility with very severe dysmenorrhea. So every cycle she had to take 1 or 2 days medical leave of pain. And what we saw, there's an endometriotic cyst on the right side. Well, during the ultrasound, we do see there are 2 uterine cavities. So the diagnosis of Clement anomaly is there. So I did a hysteroscopy and laparoscopy. And you can see in the vagina, there's a septum at the upper part of it, and 2 cervix, 2 cervical halls. Well, interesting enough, when we do a laparoscopy, from the outlook, it looks very normal. It's a very normal uterus, there's no fusions defect. But there are areas of a lot of endometriosis and endometriotic cyst. And so after the removal of endometriotic cyst, the question is, which one does it belong? When we teach medical students, these are the slides that we talk about Mullerian abnormality, whether some sort of atresia, or whether there are 2 cervix. The only one that I heard about 2 cervix is either double uterus or uterine didelphys. But there's nothing like this particular case with a normal outlooking of uterus and 2 2 surveys. So again, this becomes one of the unknown, particular that you don't normally diagnose. So I'm not the only one, and in fact, 2013, this report of a 38 years old lady who has given birth to 11 children, only accidentally doing a laparoscopic sterilization finding. She has only a unicornular uterus without rudimentary horn, with a unilateral left ovarian agenesis and unilateral left renal agenesis. Just to illustrate to you, there is still a place for endoscopy diagnosis. We cannot rely on MRI in all sorts of cases. Well, in the treatment of laparoscopic drilling for polycystic ovary, this is some hundreds of papers published and try to summarize for you. This is a Cochrane study, which is a body doing all the meta-analysis or the summary review of all the controversy issue in gynecology. It shows that the effect is only temporary to give 70% to 89% ovulation, 60% pregnancy in 2 years. But it does create ovarian adhesions and some mechanical infertility. It never can deal with the metabolic like lipid, cholesterol thing. And in fact, I did it in 1988-89. I used laser laparoscopy to drill it, and I gave it up because we do have better play. So the only possible use is, in the short term, try to avoid using the follicular stimulating hormone to make less multiple pregnancy. Otherwise, there's not many places for it anymore. On the other hand, there was this study published in British Journal OMG 2005 comparing the people who use chromatin citrate and people who use one-sided laparoscopic drilling of ovarian tissue in polycystic ovary or both-side ovarian drilling, and look at the ovarian reserve. And what it shows that on the side that you have done the laparoscopy or bilateral, those who have bilateral drilling, you definitely there is evidence of decreased ovarian reserve. So it doesn't mean there's no damage. And this is another paper published in 1999 doing laparoscopic ovarian cord-free, and shows that it decreased the male hormone, the androstenedione testosterone and free testosterone. But there's no change in the metabolic state, which is totally understandable. One of the hypotheses of ovarian drilling is actually you destroy the ovarian stroma, just like our wedge resection, to reduce the androgens production. So that is totally explainable, but again, it shows that it doesn't help in all the metabolic syndrome. Well, for endometriosis, we do surgery for endometriotic cyst, but then we always worry how to avoid destroying too much of the ovarian tissue in so doing. And this paper published in 2005, again looked into that area. It looked into the ovarian reserve in the operated ovary compared to the other intact ovary which is not operated. The conclusion again shows that in the operated ovary, when you do removal of the endometriotic cyst or some cautery for hemostasis, you definitely decrease the number of follicles, the number of oocytes and embryos and high quality embryos removed from that side. The mean decrease is about half. However, the good news is, despite the amount of the quantity is less, the final pregnancy rate is not affected, which is again understandable because we don't need 10 good eggs. I only need 1 good egg and 1 normal sperm, 1 normal egg, and make baby. So the quantity is less, but the overall pregnancy rate is not reduced. Well, we all know that for a lady who has hydrosol veins, we hypothesize that the fluid in the hydrosol veins, if they retrograde going into the cavity, will affect the implantation rate. So there is this say that if you have untreated hydrosol veins compared to a hydrosol which is removed before IVF, or in desperate cases where you find removal difficult, you just block it off by what sort of clips or cautery, you find out compared to those no hydrosol veins, if you don't treat it, the pregnancy rate from IVF is 14% against 50%. Implantation rate is only 8% against 22%. But if you do some sort of blockage or removal so that this so-called dirty fluid does not affect implantation, the result is similar to patient has no hydrosoma. So definitely there's a role of blocking or stopping the fluid retrograde in the cavity for hydrosoma before your IVF. Well, recently there is this mechanical device that you, through the hysteroscope, you put in the corneal end of the fallopian tube, and people have reviewed it in 2014 this year in British Journal OMG, and find this ensure, this is the name of the mechanical thing, maybe and other options that will save us during the laparoscopic surgery. Sometimes could be quite difficult before IVF, but we need a lot of randomized control study to do it. Well, there are cases that the ovary from previous surgery was stuck very high up. For example, this lady, 42 years old lady, wanted to have IVF, but the ovary, which has more follicle on the left side, was totally not accessible for me to do an egg collection through the ultrasound guided vaginal aspiration. The ovary was stuck below this cecum. You don't see it in the laparoscopy. So by the time I cut away the valve and I start to show these are the area, and finally when I cut away a lot of area, I finally can see the ovary, and I managed to put the ovary down in the pouch ductus. These are the two ultrasound pictures of the left ovary totally behind the uterus. There's no way my needle can aspirate unless I go through the big uterus, which means sometimes I could have lost the egg. But after the ovarian pexy, I put it down, and now I can assess, and she got pregnant after the first IVF. Well, in 1999, this report in a Hodgkin lady who needs a total pelvic lymph irradiation of 2,000 to 4,000 gray, which we just to let you know that after about 20 to 400 gray, depends on the ovarian reserve, people can cause premature ovarian failure. So what are we going to do to save her the risk of premature ovarian failure? So what they do is they transfix the ovary at the station laparotomy. And they have done 12 patients under this laparoscopic ovarian pexy, and then 2 of these was excluded because one died and one had the second malignancy. So out of the 10, 5 patients finally regained ovarian function and 1 conceived and 4 conceived. In 2 of the patients who subsequently conceived, they have a second laparoscopy and find out, interesting enough, about 4 or 5 months later, they find the ovary has migrated to the original position. So that is an interesting. But what it shows that a laparoscopic ovarian pexy before the radiation might help to preserve the ovarian function. In fact, there's a lot of papers published on it. Recently, there's the most recent review on Lancet Oncology 2013. They look at a review, and this so-called ovarian transposition for cancer lady to avoid the loss of ovarian function, usually done by minimally invasive surgery, but occasionally you can do it under open surgery. They suggest there are 3 positions, depends where your radiation is going to target. You can put it in paracolic gutter, or put it just lateral out of the other side of the tumor, that is repositioned on the opposite side, or in line of a gyral crest to avoid the lymph node periodic lymph node irradiation. And it shows that you have to counsel patient, it's not 100% work. About 10-40% still fail to do the protection. Maybe, as I mentioned, there is this possibility they may still migrate back. But nonetheless, it's still worth we discussed with a multidisciplinary meeting at the diagnosis of the cancer. Well, this was published in 2004 in Lancet by my good friend Jack Benet. He has retired, but I'm still here. In 1997, there is this lady who has a stage 4 Hodgkin lymphoma who needs chemotherapy. So before that, they do an ovarian biopsy and freeze the ovarian tissue. And 6 years later, when the patient is still well, they do a laparoscopic reimplantation in it. And 5 months later, they start to have the ovarian function. And finally, she conceived and delivered. Well, for cervical cancer in young women, instead of removing a uterus, there is this possibility. What we do, the radical tracheectomy, that is, we remove the total of the cervix, conserve the uterus. At the same time, we do a laparoscopic pelvic lymphadenectomy, and then this review, it showed that 47 cases go through it. Majority are stage 1, except 1 case stage 2. Then follow up to about 5 years, and there's only 1 complication of cystotomy, 7 because of the collection of peritoneal lymph. They have to drain it, so it's not too bad. But unfortunately, 2 recur and 1 die. But despite of 25% have late miscarriage, 13 finally have normal children. So it is again advisable, we need to discuss that with the patient, with the oncologist, what is the best thing for them. Well, for varicose ligation, it's always been a dispute. I have many disputes with our urologist consultant on whether we should do it for fertility, but this is the paper published just recently. There's evidence to suggest that varicose they start very early, even at young age, teenage or child, they have been 10%, and especially in late teenage, they increased. And this definitely shows that now they have semen abnormality, and some of them after the follow-up shows after varicose ligation shows an improvement. You're still debating which one is more common recovered. They followed about 12 to 17 years, and over 75% got pregnant. Mind you, not all have been married yet. So there seems to be evidence that we might have to do this kind of surgery even at the teenage to prevent their semen fertility affection. And there are many papers in 2014 confirm similar idea that in adolescent prevalence increased dramatically in the last part of puberty. So there is a role to consider doing in the adolescent. Of course, especially if you show that the volume decrease on the side with varicose or abnormal semen analysis. Another paper also just published 2014, again confirmed there is evidence that it affects the reproduction. So, and also in cost effectiveness, varicose ligation is more cost effective than doing the IVF. So there seems to be good evidence that as the earlier we do it, the better for fertility. Well, the only problem is we still have some question. Despite now we thought there is a role to do it early in adolescence, but which one to do it? The one with symptom or the one with no symptom? Which one is better, laparoscopic or microsurgical? How about the recurrence, the cost effectiveness if we want to do a national screening program? Finally, in the future, this paper just published in 2014 using robotic laparoscopic surgery for our fertility work, like especially myomectomy, tubal anastomosis, deep endometriotic surgery. However, there's no randomized study, and I think the role needs to be further explored. With this, I concluded, and I must say that our next generation, our reproductive medicine subspecialists, it will be an extreme pity that we'll shift them to do thousands of IVF and without doing 1 case of laparoscopy. That's what I thought the trend has to be halted, and we've got to relook in our training program. Thank you all for your attention.
Thank you very much, Dr. Chan, for your presentation. We have a little time. So, do you have any question or comment on his lecture?
No comment means I speak too fast, Mr. William. or I'm too good, either way, which is more pleasant for myself.
Well, we have OBGYN and Dr. in Japan session of ICS, but I'm afraid few OB/GYN doctor is here.
Never mind, I'll apply as an affiliated fellow.
Yeah, Dr. Eguchi.
Thank you for your, although I'm a general surgeon, but impressed very much. I am wondering what is the current role of robotic surgery, which you mentioned, in the final slide, for this kind of field or general OBG field.
Right. To me, if I still keep, even though I lost all my time in private practice now, but my review about it in robotic surgery, as far as I can see, the proven cost effectiveness, clinical efficacy is in prostatic cancer, the total prostatectomy, because there are angles that you can't do it either through a laparotomy well or through a transurethral resection well, or even through laparoscopy. I think that has been quite well proven. The robotic surgery for prostatic cancer is definitely beneficial. Other than that, there is no evidence at all. In fact, it costs too much money. I could have done an ectopic pregnancy within about 45 minutes, with 10 minutes straining all the blood away. But in order to set up the robotic, you need about 30 minutes. And the kind of consumable you're going to use is huge amount. We can't afford it in general use. All right? And in fact, it is not difficult. Anybody who's been trained with microLab, I started to do it in Singapore University in the early 90s, the first generation robotic surgery. It's not difficult at all if you have been trained in microsurgery. It's the same.
As far as I know, in the United States, 90%, 80% of the myotomy of the uterus is done under robotic surgery.
Well, the reason is it is because a lot of them are old folks. They don't want to stand up to work anymore. No, honestly, there's no evidence that robotic surgery makes advantage. It just costs too much money. And in fact, it costs, especially the simpler the operation, because we could finish a simple laparoscopic surgery, minor adhesions and a metrotic cyst within 1 hour, 1.5 hours. To set it up takes at least half an hour. And you need 2 surgeons, which I only need 2 nurses to help. Right? So in terms of cost of the people, in terms of cost of consumable, in terms of cost of theatre time, it definitely is not workable in especially public hospital. Yeah.
But I think in the United States, they are saying that they are in the same situation. They'll be able to do double cases using laparoscopy rather than robotic, but they are using it. So I'm wondering.
No, basically, these things go in America. It's good. America is very creative. They created the economic bubble and a lot of things. They are very good in everything. But I must warn you, there are so many things Americans propose, and after 10, 15 years, they all die. Yeah, and actually I got in trouble because people from under American colleague comes to me and say, why you don't do it? And I find it very difficult to defend myself because I cannot step on my colleagues in front of a patient. A lot of them they propose, but they don't stand time. Right? That's why we did it long ago, but we gave it up because I could have done a laparoscopic surgery and metrotic cyst in 1.5 hours. When you do robotic, it takes 2 hours. And you need 2 surgeons. I can do it myself. So all these add together, majority, as you can see all the review paper, there's no proof robotic surgery is definitely useful. Yeah, okay? That's my personal review. I welcome other comments otherwise.
Okay, thank you. Dr. Singh, I want to ask you, in terms of transplantation of cryopreserved ovarian tissue,
yes.
Which is talked about in your lecture. Is that used for related radiotherapy of the ovarian malignancy or something like that?
Yeah, this is the publications from the net is basically he transplanted onto the ovary again, and at the time when he did the transplant, he noticed the 2 ovaries were already atretic. So it's interesting that they still take, but as I said, I have no sort of knowledge about it. I think these are, we need our oncologists and help us. So it just will illustrate there's actually a lot of papers now talk about fertility preservation in young cancer patients. Apparently the world is getting more and more cancer in younger people who desire to have pregnancy later. So we are having a lot more coming to see.
Yeah, should be, but do you have any idea the survival rate of the transplanted ovarian tissue?
Yeah, that's what they did. They just transplant on it and it seems to work. That's all transplantation. Okay. But I think we need time.
And that's interesting.
Clinical efficacy.
Yeah, thank you.
Thank you.
Do you have any comment or question? Okay, thank you very much. On behalf of Congress President Professor Kurano and all the members of ICS Japan session, I would like to express our sincere appreciation for informative lecture. Thank you, Dr. Chen.